a hepatic ulcer. If there are eosinophils, that means a toxicity. तो अगर आपको पोलीज नजर आ जाए या न्यूट्रोफिल्स नजर आ जाए, that means it's a bacterial ulcer. अब आपने once you know it's a bacterial ulcer, फिर आपने क्या पता करना है कि ग्राम पॉजिटिव है कि ग्राम नेगेटिव है, तो then you do the gram staining. ये gram staining का mnemonic है, come in and stain. You first put the crystal violet, ये crystal violet डाला तो सारी की सारी blue हो गई. Then we put the iodine, come in for iodine, A for alcohol, S for saffron. ये आप डालेंगे तो D कलराइज हो जाएगी, जो ग्राम पॉजिटिव होंगे उनका कलर स्टे कर लेगा. तो मार्क द स्लाइड. ये आपकी स्टेन्स है, ये आपकी स्लाइड है, ये आपने सेलर गुड डाला और ये आपने देखा तो these are ये कोकाई है कि बेसिलाई है? बोले तो लंबे कोकाई होंगे तो कौन से होंगे? ग्राम पॉजिटिव है, ग्राम पॉजिटिव है क्योंकि उन्होंने कलर स्टेन किया हुआ है. तो ग्राम पॉजिटिव कोकाई कौन से होते हैं? स्टेप आरएस, स्टेप एपिडर्मिस और स्टेप नॉन. तो जस्ट बाय लुकिंग एट दिस, और अगर ये बेसिलाई होते और ग्राम नेगेटिव होते तो कौन सा होता? सुडोमोनास. सो दैट्स इजी. ये वाले जो है ये क्लिनिकली डिस्टिंग्विशेबल है, यही आपको पता होना चाहिए. बाकी की पूरी क्लासिफिकेशन के बीच ग्राम पॉजिटिव, ग्राम नेगेटिव तो कोई था ही नहीं, वो तो बड़ा रेयर होता है. वो छोड़ दो लोगों के लिए जो इसमें एक्सपर्ट है, बैक्टीरियोलॉजिस्ट है, वो जो गया. आप लोगों के लिए ग्राम पॉजिटिव कोकाई एंड ग्राम नेगेटिव बेसिलाई. याद रखें कि whenever you're looking for the slide, don't look for the bacilli and cocci, first look for the epithelial cells. जब आप सैंपल लेते हैं तो उसमें मेजॉरिटी क्या चीज होती है? मेजॉरिटी कॉर्नियल epithelial cells होते हैं. So when you see the epithelial cells, इसका मतलब है कि आप माइक्रोस्कोप में सही जगह पे देख रहे हैं. अगर आपको epithelial cells नजर नहीं आ रहे तो उसका मतलब है आप एम्प्टी स्लाइड को देख रहे हैं, आपको कुछ भी नजर नहीं आएगा. So first look for the epithelial cells, क्योंकि epithelial cells तो ज्यादा होंगे ना, cocci, bacilli ये तो कम होंगे, fungi ये तो कम होंगे. So look for the epithelial cells, then look for the Giemsa stain, look for the polyps. Polyps means bacterial. When you see the bacterial, then do the gram staining and look for the gram positive cocci and gram negative bacilli. Thank you very much for your time. And the next speaker is Dr. Hamza. Hamza is here. Hamza, Hamza will talk about the stepwise approach to the bacterial keratitis. Thank you very much.
Of cornea or conjunctiva, they are gram-negative cocci and corynebacterium diphtheria. No other microorganism, including the fungi or the viruses, can penetrate the intact epithelium. So, practically, we have to have some predisposing factor to have a corneal ulcer. And here comes the physiology of the protective mechanisms of the eye, including the blinking and the lid, including the tear film, including the surface integrity of the epithelium. All these are protective mechanisms, normal protective mechanisms against the wet disease. So, if they got an intact mechanism, there are very less chances of having a ulcers of the cornea. It is only the corynebacterium diphtheria, fortunately they are now there, the gonococci and gonorrhea, they can penetrate. And so that's why Professor has not mentioned them, because practically we are actually seeing all of these, except in very few cases of nausea and pneumonia. So it is extremely important to see the predisposing factor. This is very important in the management. And one thing, we don't have to, not every patient having a injury with a branch of a tree or any of the things is going to have a fungus. In a very large study in thousands of patients which have got this agricultural injury to the cornea, to the branch of a tree or something like this, not all of them, very few, they develop a fungal keratitis. And most, thank you so much.
Assalamualaikum. I'm Hamza from Karachi. Thank you very much for giving me an opportunity to speak in front of the respective audience. So I'll be quick and precise. My topic especially for residents, there will be some basic things which probably you already know, some slightly different things. Okay, so I apologize initially if you already know things. These are my association, no financial disclosure. just to give you a brief idea, cornea has 5 layers. So what I say to myself and my other colleagues and the residents that we have 5 days to diagnose the ulcer. Okay, 5 days, 5 layers. As you delay the things, as Prof said, there are some bacteria which are very fast and they can actually go deeper and then can cause more of the drama. Now, but first thing first, you have to measure the size of the ulcer, you have to measure the depth, you have to measure the characteristics, and obviously the future planning. And that handy comes in terms of the OCT. That's my first thing for you to remember. What is corneal ulcer? Is basically an epithelial defect, which is necrosis of the surrounding tissue. You can have the edema, keratitis precipitates, and later on angiogen variation leading to hypopion. That is basically a severe keratitis. But in a nutshell, not all of the characteristics should be there, but at least 2 or 3 should be there to diagnose with an ulcer. Now, the diagnostic approach, first of all, we have to profile the ulcer. What it is ulcer about, category, bacterial, fungal, parasitic, or any other atypical bacteria or non-infectious even. So when the patient comes to you, ask about the pain. This could differentiate many things in terms of if the pain is severe, when pain is moderate, pain is like a toothache, it's like a dull ache. So you can actually get the idea what the patient is suffering from. A fungal ulcer have a less of a pain compared to the bacterial ulcer. Same goes for parasitic, like acanthamiba have severe pain compared to the other etiologies. So what I suggest is obviously the pain is the most important thing. And then you talk about the non-infectious ulcers, like we talk about the history in terms of rheumatoid arthritis, autoimmune disease, Sjogren's syndrome, leading to the corneal melting. So these all can contribute towards the ulcer. Now, context should be very important. Where the patient lives, environmental conditions, the workplace, like in Karachi, there are lots of construction going on. So people are on the bike, they get something into the eye and then they come into us. So these are the things which can actually tell you or guide you where you are heading towards. Not necessarily the diagnosis, but at least the first approach, what to do if the patient ended up with the A&E or if it's the first time in your clinic. Then examine the site, culture the site, definitely. Don't forget the culture is the main thing, although the specificity and sensitivity is about 70%, but don't actually negate that. You should always, wherever possible, do the culture. Now, when to refer, it's basically for all those who are non-cornea. Non-cornea means like who are not trained in the cornea, like a general ophthalmologist or glaucoma, retina, wherever. Please make sure that you don't let the ulcer go deeper layers. There's no point of sending the patient to the corneal consultant when the ulcer is very deep, hypopion, big infiltrate, because that's more of a rescue thing rather than a treatment thing. Okay, because if you send this patient to the corneal consultant, what will you do? Finish with the therapeutic keratoplasty later, isn't it? So there will be a scar, big scar. So you have to refer the patient when you think it's beyond your capacity. So understanding your limits is the main key here. There's nothing wrong in understanding that you can't treat the patient. The patient would actually appreciate that you actually help him and send him to someone who is more specialized, who is more trained in that pathology, diagnosis of the pathology. So please, what I say is if it's going beyond 200 microns, or if the ulcer is not healing in next 5 days, please refer the patient. Okay? Stepwise. So coming to point, always do the OCT to characterize the ulcer. Scraping, obviously, as Bob has already told you about. Then you get the confocal microscopy. It can differentiate between the fungal as well as the acanthamiba. So even though you're not suspecting acanthamiba, but you're suspecting fungal or bacterial, because some of the advanced bacterial infections can actually mimic like a fungal, and you wouldn't be able to differentiate, and the culture doesn't grow anything. So you can get the confocal, and that in those scenarios you have the availability, and then least thing what you can do is like a corneal swab or the conjunctiva. Corneal swab means going on the lesion and then scripting a little bit on top of it and then setting it. This is the least you can do. This should not be your first thing, but if you don't have the facility, keep some swabs in your handy in your clinic. Even if you're a general ophthalmologist, at least send something so that we know what's happening. Features, Prof already discussed quite a lot on it, but I don't want to go in further details. But in a nutshell, you can say there are characteristic features of bacteria, acanthamiba, fungus. Now, biryani slide, why I'm putting the biryani slide? Because often the unseen is the most important. When we say the calories, obviously we don't know how much calories in the biryani. Does anybody know here? No, we don't know. And it all depends on perspective, okay? So the reason of featuring is that you need to see the unseen or actually diagnose the unseen. And that comes to the treatment protocol, and the treatment protocol for in Pakistan, what we do is a simplified bacteria. You get the patient, you suspect the bacterial, start with one single antibiotic, a broad spectrum moxifloxacin, or if the patient is recommending a view with a large infiltrate hypopion, obviously moxifloxacin probably not going to help. So you start with the vancomycin covering the positive, you start with ceftazidime covering the negative. If you suspect the bacterial, obviously if you suspect the fungal etiology, add the netamycin. Netamycin is less toxic of the other drops like Vori and the Ampho, but netamycin won't harm. I mean, just give it like 4-6 times a day to see if the ulcer responds. Okay, so you just need to make sure in next 24 to 48 hours it is improving. If it's improving, you go into reduction phase, which is initially it's hourly, day and night, and then you go to like 4 times a day. Or if it's deteriorating, then you must need to know what causes the deterioration. It could be something which is not bacterial, or you think it's a fungal, but it's not fungal. So you need to question the diagnosis, or better refer to the patient, as I say. Try not to go beyond that. So when we did a protocol for managing care, you just take a slide photo of it, because I can't just go through limited time. But this is the protocol for the managing deteriorating keratitis, Morpheus protocol, not my protocol. So I usually follow this, and it's actually sometimes helps, sometimes doesn't, because the amount of keratitis or the infection we get is very big. At least I get very late stage keratitis, which more of a resolution or a rescue rather than me treating the patient. But if you get a patient, try to follow this, what to do, when to question the diagnosis. Helpful points: molds basically ulcers are grey and dull, but the yeast have better defined borders. In fungal, you have to. Okay, 2 minutes, fine. So dull and grey the molds, and then you go yeast is a better defined borders, relatively small epithelial ulceration. And mind you, when you say fungal, don't just give everyone amphotericin, okay? Because this is what usually people do. So you need to define whether it's a mold or yeast, either confocal or culture, or your clinical diagnosis, okay? Because don't forget, they all are detergents. They all are very toxic to the eye. So I usually keep the amphotericin for the immunocompromised patient, or if I suspect the candida. Otherwise, I don't give the amphotericin. I usually do the natamycin and the voriconazole. So this is what I said: amphotericin for candida or other candida species not responding, voriconazole. Mud trial, I have limited time, but mud trial is a very good trial, which was a mycotic treatment ulcer trial. Go and have a read about it. They came up with the natamycin was superior to the voriconazole, which is yes, but obviously in our part of the world things can be different. This is published 2023 in EU Cornea, managing fungal keratitis. Voriconazole to start with, natamycin if you want, poor response, intrastromal, poor response, then go for the keratoplasty, rather than keeping the patient for months and months and the ulcer going deeper, hypopion. Just do the PK if it's deep, or if it's not too deep, do the dot. Okay, save the eye, save the quality. Non-compliance leads to failure. In Pakistan, it's very common. Be it ulcers, be it corneal graft, be it glaucoma. Non-compliance is question always on non-compliance. Just to give you last 1 minute, this is the patient who had the aspergillus keratitis. Reason I'm showing here is this big. Quick. So you can see the infiltrate, deep infiltrate. The patient's been to the cold desert in Iskandar. I would love to go there, but never been there. You can see the branching vessels here. So this is the hallmark of the aspergillus fungal keratitis, and I'll show you why. Not one case. I've got many, and this is what I have come up with. Hopefully soon it will be published as well. The ulcer go deeper, concise, not surrounding tissue edema, and then it just go deep and with the high T pattern. Okay, and the main differentiating point is this branching. Now let me show you. This is ulcer healed. It's not checking now. What's the light from here? Can you sufficient?
इसी पे
फिर तुम्हें जो क्या मार दो यार, ठीक है? Just trust me. यहाँ पे देखना. ऐसा दूसरा, okay. You can see the ulcer has healed. Again, the quality is, sorry about that. Again, this is big infiltrate coming out of the cornea, hypopion. ये भी नजर नहीं आएगा. बस मुझे 1 मिनट तो देखना. 10 मिनट की बस. Okay. Okay, again, branching pattern is not. I'll just show you. If anyone interested, I mean, just come to me. I'll show you. The reason I'm saying aspergillus has a characteristic branching pattern of the vessels, which you can get out of it. Okay. Thank you very much. So don't have the time to proceed. Just one more thing. Last thing I just want to say is we don't have the magic wand. Okay. I made it from the AI, so I had to show you now. Come on. I spent some time. Pseudomonas ulcer, very quick to go into the eye. This is just 2 days patient history of contact lens usage. Okay. It can go deeper, it can cause hypopure, it can cause large infiltrate. The patient came to me once, I don't know where is he gone, but I know clinically Pseudomonas came out Pseudomonas from the culture. It started the treatment, patient, I don't know where it is. But what I'm trying to say, Pseudomonas are very, very fast growing. If you wear contact lenses, suspect Pseudomonas. It is that sort of picture in 2 days time. Thank you very much.
Very much, sir. And the next speaker is Professor Elvin Young from Hong Kong, and he'll be talking about the
First of all, I want to say sorry. I didn't know, I was not informed of my audience or sort of level of how many people, etc. So this is a rather generic talk that will apply to everyone. And then if I'm not clear anything, you can ask me afterwards. It's a small enough group, it's pretty informal. You know who I am. It's not very good. No, I don't have to, but the display is not very clear. Is it? Can you see? Okay. No contact mentions. This is an outline of my talk, and the previous speakers have covered some of the stuff, so I can actually go fast and skip it. You know this. So, first speaker, as already mentioned, I can't remember which speaker. Some organisms can penetrate intact cornea, but most would actually need to have some sort of mechanism before it can infect you. Break down the mechanical barrier, virulence of the organism, and compromise the immune host. So it's an interplay between these 3 factors, really. Whether you get how nasty your cornea ulcer infection is. Decision making. Always at the back of your mind, you should think about whether this can be an immune ulcer rather than an infective ulcer. Now, obviously, I mean, with more experience, there's no absolutes in diagnosis of corneal ulcers. With more experience, you would get a feel whether this can be immune or whether it's infective. Okay, previous speakers have given a lot of pros on how to diagnose clinically, so these are the great things, and I don't need to cover. But there's one thing I want to bring to your attention. You kept saying bacterial ulcers. You need to know your prevalence of your country or your region. Okay, in China and India, the top prevalence is fungus ulcer, not actually bacterial. So this is a gross general geographical map of the world in terms of corneal infections. Gram-positive cocci, gram-negative bacillus, fungus, etc., etc. Okay, so for Hong Kong, for my area, it's always bacterial. We don't get any fungal ulcers. We do get Ancanthamoeba because of contact lens wearers, etc. So you should be weary of the patient's travel history or where they are from, or in your locality. You need to know your local biology. And also, one more thing I think was not stressed enough in the previous talk was probably your history. Okay, talk a lot about science, talk a lot about investigations and tests, but the history can actually give you pointers as well that I do like. This is just an overview of what you need to cover, and I probably don't need to repeat what previous speakers have spoken. Okay, so perforation is a serious, sight-threatening thing. It's an emergency that you need to deal with. So these are the goals of surgical treatment in infected ulcers. Get rid of the causes, restore the structure, suppress the inflammation, you need the medications, and relieve pain. Don't forget that because patients are painful. We published this paper a few years back. This is just a workup. You can refer to the paper if you want to read more details because it's, I want to keep it in time in 10 minutes. So I'm not going to go through each one of them on the slide. So these are the options that we have. In terms, it hasn't really changed much. Contact lens, collagen cross-linking is question mark. Simple glue, labs, amniotic membrane, various types of corneal grafts. Latest fancy is people are doing button grafts and endothelial grafts at the back of corneal perforation. I'm not a big fan of that, especially in infected cases. And then last resort, evisceration. So surgical therapy, always follow a trial of appropriate medical therapy. This should be the last resort, except in very severe infections or corneal perforation. So these are the considerations when you, whether you think you want to proceed to surgical for corneal infections. The morphology of the thing, the location, the size of your infectious keratitis with perforation, and also the availability of tissue and expertise. If you are not able to do whatever you can do, then that may not be a treatment option for you. Back to basics. How do you take a point of scraping? This is actually surgery. You should take active edges from the active edge and not just the slough at the base, okay? And you should use proparacaine because that's the least effect on your bacterial samples. If it's a deep infection, this is one way you can do it. This is not the only way. You can actually pass the suture and then send the suture because the suture is going to collect some sort of material on the thing, and then you can just cut the suture and then culture it. What about if it's deep? I think first we can talk about endothelial parts as a fungal sign, right? So if you need to take a sample, you can actually stick in the needle, paracentesis, and then just sample the endothelial part as well. Okay, corneal biopsy. Usually you should take more than one site. And just remember, when you take the biopsy, send for microbiology and also send for pathology. It will help you a lot in diagnosis. Take from different areas, and again, take from the active edges. This is it will facilitate diagnosis as an incisional biopsy with a small 2mm biopsy compartment. If it's a deeper lesion, such as the posterior stroma, you can do a trapdoor biopsy. Just open a lamella flap, and then you can access to the posterior part of the eye, and then you can biopsy that area as needed. If there's a huge infection, it's like the whole cornea is involved, you can actually do an excisional biopsy. Obviously, you may need further surgery in the future to restore the corneal integrity. This will serve to remove the sort of debulking, get rid of a lot of the infection, and you have a lot of tissue for sampling afterwards. Glue. This is the basic that every, I don't know what a corneal surgeon, even general surgeons should know. Okay? There are many different ways of doing it. This is the elegant way described. Okay, you put a block of glue on top of a sheet, on top of a food ointment, so that you can stick it onto the cornea with a bit of air, and then you insert that perforation. I have a simple way of doing it, and I don't bother doing that because I think it takes longer. This is my way of doing it. Just a needle, okay, 30-gauge needle, connect to a syringe, with some glue, and then you can actually juggle how much glue you actually put onto the perforation. This is a short video to show you. This is a perforation. So first of all, I just want to see how bad the leak and whether there's any defect. Create a raw surface so that the glue will stick. And then with the titration, you can actually small block of glue into the exact area. I just seal it like that. And then after that, this is an effective case. So afterwards, we just do an AC tap, and then otherwise we also give a intravitreal antibiotics as well. Amniotic membrane is the next thing. There are many different techniques described: inlay, overlay, sandwich, etc. So this is a good adjunct, but it's not something that can cure everything. It can be sutured. I mean, yesterday after my pterygium talk, a resident came to me and said they may have issues about funding for sutures and asked me how to stick on dry. Autologous glue is possible, but I don't think autologous glue will work for AMT. Okay, but so you need suture or fiber glue for the AMT. Put in a BCL afterwards, and then up to 3 millimeters perforation you can use AMT. If it's larger, I don't think it will work. So this is a nasty mycobacterial monster. She already lost the other eye. Okay, so I've already put some cyanide glue at the bottom before, but she's still extending. So I just want to cover the area, give it time to recover before I do more. So I'll put in multi-layer AMT in that defect there, and then later on, it was a match I filled that gap and then I just put a few more on top of that. It can be shown by the OCT as well, intraocular CT, but it's not played by the mobile. Okay. Lamellar keratoplasty. In patients with peripheral ulceration, a lamellar keratoplasty can be performed. It can be used to find a small perforation as well. And these are just some examples of peripheral surgeon, and then a presenting lamellar perforation and a sort of circular repair or prosthetic repair. It's up to you. You can trim it according to the need of the surgery or the lesion. And then if it's big, as the previous photo and the next one, you might need to do a large diameter eccentric graft for both. And if extensive areas involved, DALK, deep anterior lamellar transplant, is very, very good for infection, but it's very, very difficult in an infected eye when the eye is soft. So again, that's why I'm saying it depends on surgical expertise, what you can do for the patient. So this is an example of a nasty big infection there, and there's a total keratoplasty, a bit eccentric to cover the area. So keratoplasty, DLK is difficult, PK is not so difficult. Best performer in GA because you can expect problems of bleeding, pressure, upthrust, especially in our Chinese eyes. There's a lot of pressure always. Okay, I don't want any explosive hemorrhage. Surgery has to be very meticulous because these are sick eyes, these are inflamed, these are infected, and there's usually a lot of gunk and fibrin when you operate. Okay, you should be as quick as possible because prolonged hypotomy will lead to further risk of choroidal detachment and even explosive. And then the standard suturing, tenonylon, and appropriate antibiotics, either post-op, topical, and intracranial as a punch. So this is an example of an infective, nasty pseudomonas keratitis involving the cornea and the sclera. So I think my fellow did this case. We took off the cornea, there was so much pressure, and also everything was stuck. The lens was stuck to the cornea and the iris as well. So after they opened up the eye, you can see the iris, the lens, everything is stuck. So we just get rid of the lens, very quick AV, and then just put on the cornea. You should be quick, and this was obviously under GA. And put on a Beringa ring if you can. So this is just a summary slide. Infection control, control the inflammation, control the infection. Topical steroid is a big no-no to eat, unless you're very sure the infection has been eradicated. Flu for spontaneous detachment and the ultimate grade disintegration. You have to look for these post-op. In terms of healing, look for CDOs, test whether it's leaking, whether there's we have to do relaxation after your surgery, and make sure there's no invasion and infection into the anterior chamber, the sclera, or the posterior chamber. So, just a summary: work up, assess the size, repair, and then monitor post-op. So, thank you for the Society of Pakistan. I'm very honored to be here, and my team back home. And as I said, Asia Economic Societies and Hong Kong if you want to come. Thank you.
Thank you very much, everyone, and thanks for being involved and finishing the entire starting. And the last speaker is Professor of the Night. He'll be talking about the non-infective therapies.
The non-infected types of ulcers, they are related generally by to this, like Stevens-Johnson syndrome or Moodle's ulcers or staph blepharitis related corneal problems. So talking about, I'll not go into the theory of the Moodle's ulcer, but I have to say that the Moodle ulcer is of unknown cause. Generally, we don't understand what is going on while we are considering the Moodle ulcer. Evidence is mounting that the autoimmunity plays a role, and there are certain observations which led to this concept of autoimmunity. And one of the clinical observation that the proximity of the ulcerative lesion to the limbus probably has pathophysiological importance because resection or recession of the limbal conjunctiva can often have a beneficial effect on the ulcer. So again, it is suggestive of some immunological response which is mediated by the blood vessels and the peripheral cornea. The still knowing, not knowing the geology, certain precipitating factors are there and which have to be considered. They may be as considered as eliciting factors or maybe precipitating factors like accidental trauma, surgery, or exposure to the parasitic infection. These parasites are particularly in our part of the world, we have to ask and we consider patients that किसी आपको worms की स्थिति नहीं है तो is very much concerned कि आंखों के इलाज के लिए डॉक्टर मेरे पेट का क्यों पूछता है तो पुरानी कहावत है ना कभी पेट दर्द हो तो उसको सुरमा दो ताकि वो देखे कि वो दलील रोटी न खा ले तो there are sometimes there are things are related so the parasitic inflammation infestation could be inquired. Now, I'll show you only few of the features of ulcers. This is the time. Still, there is a very, it's very different in front of me and here. But you can see that there are three areas of inflammation. It starts with one, and then you can have another, and then they collide with each other to form another. Expanding internal infiltration, and then the surface becomes ulcerated as well, and it may go into. So it is very rare to see this at this stage of the noodle ulcer. When the patient comes to us, it is obviously a characteristic ulceration of the noodles which you can see, but it could be like this as well. And this is what is. You cannot see anything there, but actually there is an elevated area of the ulcer on the center side and extending from this area to this area. ये तो बहुत ही यार कुछ भी नहीं नजर आ रहा है इसमें अल्सर कैसा नजर आएगा उन्हें तो पैटर्न दिखाने हैं कि कैसा पैटर्न इसमें हो सकता है इसलिए इतना निकम्मा सिस्टम है तो आप जरा बुला के ले आते हो मैं गाता वो कहते हैं कैसे बुला के थे क्या This was a very young patient which had got you can see the blood vessels which are, this is an inflamed area adjacent to this ulcer area, and this is extending from this area. The nodal ulcer, they not only extend towards the center of the cornea, but also they extend along the periphery of the cornea, and sometimes if it is not, it is progressing and it is not being controlled, it is ignored by the patient. It sometimes goes to the whole 360 degrees. And the typical, I'll show you the picture if it is clear on this. So, this was a patient, a young lady, she already lost the other eye due to the same recurrent nodal ulcer. And this was the only eye, and we tried to save the eye by doing multiple small peripheral grafts. If it is seen, you can see there is a small graft here, there is another graft here, and from this area to this area there was a third graft. And only in the center there is a small clear cornea by which she could see about 6 by 6 division, and it was really helpful for her to continue her life. So then there was a very young patient, about 20 years of age, and he got bilateral nodal ulcer. One was on the inferior side, and the other was in the right eye. It was on the inferior side, and on the right side it was superior extending about 180 degrees, and it was extending towards the center. And still in the right eye because it was a heel ulcer, so he could see about 6 or 6-9 million. But on the left side, it was very less, it was about 60 million. These are the pictures that this is extending the right eye, but this is the area of the ulcer, and this is extending from this area to this area. This is another patient. She got a very large ulcer on the nasal side, and it was again treated by a peripheral centric corneal graft. This is a very young patient. He had got this ulceration extending from this to this area with the prolapse of the iris inserted. All this area was a thinned area, and we can see the iris through it, but still not perforated. But at this area, two areas where the iris was collapsing, and so we have to go for a concentric graft. And we look at this. This was the graft which is extending from this area to this area, and we were able to save the eye and a bit of the vision. And the last is this very it's a very chronic ulceration. And what are the meaning of a chronic ulcer? Chronic does not mean that it is there for a period of many days or months or weeks. Chronic means when there is evidence of simultaneous inflammation and healing process. Chronic inflammation means when there is a simultaneous continuous inflammation along with the healing in certain areas. जैसे ऐसा बता रहे थे pneumococcal में कि a certain part is extending already and the part which is initially there healing at the same time. This is what is the type of a chronic ulcer. So the rural ulcers are chronic type of ulcers, and still, although the resolution is not good, but still you can see this line, which is zigzag line, is actually the area of the cornea which remains clear in the center, and whole of this peripheral part of the cornea up to the middle periphery, all it is thinned out. It's very thin. It is less than 1/4 of the thickness of the cornea, and all is vascularized. And sometimes it happens that just like a hard contact lens which is placed in the center of the cornea, all other area of the cornea is thin and vascularized. Vascularized means healed. If you put a fluorescein on it, you may not be able to see a stain, but still it is very thin and vascularized healed area. And the central part is it possible to see the blood vessels here? It's a very large blood vessels which are extended forward. So these are different presentations of the movement you may come across. Very early, you can see only the infiltration or small infiltration, and when it progresses towards the center and around the periphery of the cornea. And as I've explained, the chronic ulceration, probably of a neurological nature, and there will be the signs of healing and scarring in the form of vascularization, and there will be an extending or progressing part ulcer as well, showing that it's still a ulcer. I'm not discussing the treatment, but I just wanted to share the different presentations of these. Thank you very much.
Thank you very much, all the presenters, and for the talks. I think the next session will start up sometimes. If there are any questions from me or Amza is not here, if there's a question also you can ask. The next session will be 10-15 minutes about.
I want to comment on bacterial or fungal ulcer, particularly the fungal. The hypopion, the convex hypopion, which you consider with the suspect of having a fungal ulcer, please always check the position of the hypopion by changing the position of the head.
A couple thousand.
So it is available in Pakistan with the name of Blue Brand 2, and its price is around 52,000. I'm using it. Blue Brand 2.
52,000 में तो आपका सारे में
But sir, वो आपका एक patient पे ये 2 ml होता है सर. You can use it like maybe for on 10 patients you can keep it because already infected patient.
You need to plan your risk. You want to do it in many patients and with one glue because basically it will set. So unless you can do it very quickly, otherwise your glue may set and you can't keep it that long.
ये जो आप स्लाइड्स बनाते हैं स्मीयर देते हैं वो देख के खुद ही बनाते हैं खुद ही देखते हैं या लैब को देखते हैं
खुद भी बनाता. I've got a trained technician. He does that. I take the sample, I put it on the slide, and the rest of the work is done by the technician.
अगर किसी को लैब पे भेजना हो तो कैसे भेजना है?
Okay, you take a sample. उसमें आप करेंगे 3 स्लाइडें लेंगे कम से कम एक जो कि दैट इज फॉर अ माइक्रोस्कोप just to see कि इसमें फंगस है कि बैक्टीरिया है आपको फंगस के हाइफी नजर आ जाते हैं तो दैट्स फॉर दैट just put the small sample on the slide and look under the microscope straight away आपको हाइफी नजर आ जाएंगे स्पोर्स आपको नजर नहीं आएंगे so that's for one and the other 2 slides are one is for the ginseng staining and one for the gram staining
तो आपको सेंड कैसे करना है उनको किसी मीडिया में कैसे रहेगा
कोई मीडिया में नहीं आपके पास ही होगी जस्ट को सेंड करें और उसको सेंड करें
If you don't have the microscope and electrician, but you have to keep a box of light take the sample from storage stepping and put it on the slide. It will dry up and it's good for the staining. And just send it to the person who can stain. Usually it's not, I mean, recent when we were doing training, we got a microscope in our ward and we just put a drop of, it's very practical that we got a fresh KOX solution, we put a drop of KOX solution on it, look through the microscope and see whether you can see the fungal activity or not. It is very important to know that this ulcer is not having a positive fungus. If you know that, doesn't matter, you go for a treatment for bacteria. If you don't have a clinical sense of seeing that this is fungal or although you can explain in very details, you can know that is a fungal or ulcer. But to confirm that, just put a small, the superficial exudate which is present on the ulcer is not going to have any ulcer. You just discard it. And then you scrape a little bit and very little amount of the material you got, put it on the, with your 50 number grade, you put it on the slide and that's it. Nothing have to, you don't have to do anything else.
सर आपके आपके कवर
किसी कवर की जरूरत नहीं है you just don't have to wipe it up away while you are transporting it.
सर आप ऐसा करें कि आपकी जो ये स्लाइड्स होती है ना जो बैक्टीरियोलॉजी वाले टेक्नीशियन होते हैं they know much more than you.
Yes.
तो आप उस टेक्नीशियन को कहें कि मैंने क्या करना है he knows that ये आपकी तो स्लाइड कभी जाती है यूरोलॉजी में से गानी में रोजाना 50 स्लाइडें आती हैं तो ये भी डेली जिनसे स्टेन ग्राम स्टेनिंग को वो यूज कर रहे होते हैं जैसे आप दोनों का एंटीबायोटिक ड्राई आई पे ड्रॉप से दे रहे होते हैं तो आप अपने टेक्नीशियन को कहें आपका टेक्नीशियन आपको बताएगा कि क्या करना है
कुछ भी नहीं करना स्लाइड जस्ट टेक
कुछ भी नहीं करना
the center of the slide and send it. That's all.
एक बात याद रखें
की जरूरत नहीं है कोई पानी नहीं डालना कोई
एक बात याद रखें कि जब स्लाइड
कुछ नहीं होता
साथ में कल्चरल सेंसिटिविटी के लिए मीडियम के ऊपर जरूर इनोकुलेट करें
तो वो कहाँ से लेना है वो कैसे करना है
सर वो आपके पास फ्रिज में पड़े होने चाहिए ब्लड एगर चॉकलेट एगर आपके पास फ्रिज में पड़ा होना चाहिए
So the body should be in the hospital then.
सर आपको सिर्फ एक फ्रिज चाहिए होता है आपके डिपार्टमेंट में पड़ा हो कोई भी फ्रिज हो उसको वो मीडियम उसके पड़े होते हैं एक सेट मीडियम का पड़ा हो जब वो चले जाएंगे तो आवाज दूसरा लेगा
प्रैक्टिकली वैसे सब सही कह रहे हैं प्रैक्टिकली लेकिन जो हमने उसको ये भी कंफर्म किया है कि how much is the sensitivity of the staining with the slides and how much is the sensitivity of the ulcer. It is equally good having a positive or having an examination on the slide. Doing this three, Gimras में आपको cell मिलेगी और ground staining में आपको bacteria का मिलेगा और fungus का. Even sometimes you send it for a PAS stain that is very, accurate and good for detection of the fungus and the entamoeba as well. If you have got a good laboratory. I've got a lab from about a walking distance from 1 or 2 minutes, and I send directly the patient to the lab, and they do it, and they give me the result within.
जितना भी आप एक्सपेक्ट करो आपको नीबा का आपको बैक्टीरिया उसका ग्राम पॉजिटिव नेगेटिव पता चल जाता है सेंसिटिविटी का पता आपको कल्चर से चलेगा कि कौन सी एंटीबायोटिक उसके ऊपर एक्ट कर रही है कौन सी वो कर रही है दैट्स ओनली बी डन बाय द कल्चर सेंसिटिविटी so that's why we do culture
क्वेश्चन मुझसे पूछा था कि जी आपने तो ले लिया स्क्रैपिंग ले लिया स्लाइड पे लगा लिया अब आप ये स्लाइड ऐसे घुमाते हुए बॉटल पे ले जाएंगे
सब घुमाते हुए नहीं लेके जाएंगे आपने उसके ऊपर मार्क किए मैंने आपने एस मार्क किए आप उसको डब्बे में बंद करिए एक डब्बा अपना रख लें डब्बे को बंद करके डब्बे में बंद करके उसको भिजवा दें लेबोरेटरी पे आपसे 10 मिनट दूर तो नहीं होगी हॉस्पिटल के अंदर ही होगी सारे सैंपल जाते हैं इस तरह ओके जी थैंक यू वेरी मच
सर एक्चुअली आजकल का कॉमन हो रहा है हमारे यहाँ पे उसका क्या ट्रीटमेंट है कोई खास अवेलेबल तो नहीं है
सर एकेंथमीबा आपको अपने लैब्स में पता करना पड़ेगा। बीटोनाइट जो है आप खुद बना सकते हैं, ये वो जो स्विमिंग पूल की जो सोल्यूशन होती है ना, वही चीज होती है, आप उसको डाइल्यूट कर सकते हैं। लेकिन अगर आपके लिए आसान काम है तो व्हाट यू डू इज कि आपको जो स्पेयर होता है ना, जो सर्जिकल स्पेयर होता है, वो स्पंज होता है, तो उसको 5% पाउडर आयोडीन में स्टोर करें, तो 3 मिनट तक उसको स्टोर कर रखें, और उसको असर को करके उसको 2 दफा करें और उसको डेली रिपीट करें। दैट गिव्स ऑलमोस्ट क्लोराइड आपको स्विमिंग पूल सोल्यूशन मिलती है। तो आपको ये जो शॉप्स होती है ना साइंटिफिक, उनके पास क्लोराइड होती है, कितनी बड़ी बॉटल होती है, उसको आपको डाइल्यूट करना पड़ता है। लेकिन आप वाइकोरोजोल इस्तेमाल कर सकते हैं। वाइकोरोजोल एंटी फंगल है, डिक्लोफेन नहीं करना है। वाइकोरोजोल अवेलेबल है, वेरिऑक्स के नाम से अवेलेबल है, शाहबाद में, कराची में, लाहौर में अवेलेबल है। थैंक यू वेरी मच सर। आप कोई भी बना लेंगे ना, फॉरेन बॉडी सेंसेशन होगा तो उसका पीएच नॉर्मल नहीं होता। उसका पीएच जो होता है ना वो 7.4 नहीं होता, उसका पीएच डिफरेंट होता है। तो उसका थोड़ा सा सैलान के 2 ड्रॉप डाल दें तो उसका पीएच डाउन हो जाता है, तो अच्छा हो जाता है।